Hi, this is Elliot Fishman, and welcome to part 3 of the role of AI in the early detection of cancer. Last time we were finishing off talking about radiomics, how radiomics has the ability on early detection of pancreatic cancer, also classification and becoming a pathologist, for example, talking about neuroendocrine tumors, and also talking about being a super radiologist, looking at cystic pancreatic lesions and predicting what they are with an accuracy far better than radiologists. So again, we're talking about the ability to affect every part of the process of what we're doing. Now, this idea about distinguishing tumors is very important. We'll know who to biopsy, maybe who to follow, who to operate on. One of the things this article makes the point, we anticipate the establishment of standardized radiomics guidelines in the future to provide more evidence for the diagnosis and treatment of pancreatic cystic neoplasm. So what we're saying is that with radiomics, we will have to change not only staging of disease, but how we classify disease and how we recognize disease. And again, you can imagine when we talk about everything that relates to prediction, again, good example, CT-derived radiomics features predict rapid tumor progression following SBRT, confer nearly a twofold increase in mortality risk, and along with the patient age, enhance the identification of patients with stage 2 and 3 pancreatic cancer with poor overall survival. So again, if we can predict the patients who will do well with therapy, as well as the ones who will do poorly, we could change how we do our therapies in the latter group of patients. And again, one of the things we really want to think about, we always talk about personalized medicine, and we are doing better in that regard. But the future really is personalized medicine, personalized therapy. And that's what radiomics can help us find. And in this other article by Kim talking about the American Society of Clinical Oncology, at their meeting, we developed machine learning models that can compute the probability of overall survival based on routinely collected data from our patients with advanced or metastatic pancreatic cancer. To the best of our knowledge, it's the first machine learning solution aimed at aiding clinicians in the selection of first-line chemotherapy regimens for pancreatic cancer. Again, we're talking about AI impacting detection of disease, staging of disease, and managing patients with disease. I mean, the ultimate in personalized medicine. Now, other things we're working on is working with the computers to be able to have the computers become a super radiologist. We mentioned we miss 40% of lesions. We mentioned that radiomics can perhaps predict the presence of a lesion even when you don't see it on the CT scan, even when you know it's there. Well, the other thing is, can we have the computer help us recognize tumors as we're reading scans? So we taught the computer to recognize the varying structures in the patient. We taught the computer to recognize the pancreas and literally draw its outline, as well as a radiologist can do it, or even better perhaps. We taught it to segment out the various organs. We taught it to become basically a radiologist. And then we taught it to be able to recognize the presence of a tumor, looking at deep network predictions of tumors and the ability to find lesions that are going to be small. Now, this is a bit larger tumor, but you can see the tumor, the pancreatic duct, the glandular atrophy. And again, this is how we develop things to be able to pick up even smaller tumors. We teach the computer to recognize the pancreatic duct so that we can pick up small tumors that are invisible, but the duct leads us to the tumor. We're also working on being able to look and evaluate the common duct. Remember, we talk about a double duct sign. Common duct is important. You may have a single duct sign, or a pancreatic duct is important. Together, they're very important. Can we put all that information together and have the computer be able to read that information? We talk about, in this article, deep neural-based segmentation of normal and abnormal pancreas. We talk about the ability to develop algorithms to recognize the pancreas. Manual segmenting takes us more than an hour a patient, even after all of these years. Can we do it where a person is not involved, or perhaps the radiologist or technologist only makes a few minor edits? That would be fine and spends a minute or so, particularly if you can get rid of the manual editing in most of the cases. So we talk about how the computer can be trained to recognize the range of glands and the range of glands with tumors. Again, this is all challenging, but it's work that is being done. In conclusion, our study found that segmentation of the pancreas using deep neural networks is accurate and can be applied for AI-based volumetric analysis in the majority of cases. So again, we're working hard on that. And if you need and you want to have AI be involved in real-time patient care, it's not going to be the radiologist or technologist segmenting all of these cases. And you really don't want to have them look at it. You want the computer to do it. And if the computer has an issue, the computer needs to recognize it's failing and then say, hey, a radiologist needs to look at it or edit what the computer has started. I think that's the method and that's the plan that we have. When you think about the whole process, this was an article by Matre and Eric Topol talking about, looking at pancreatic cancer and detecting early cancers in all patients. There is some excellent work going on, Mike Coggins, Mimi Canto, for patients with high risk, but that's a small number of patients. What about all patients? Can AI look at the medical records, look at the images, and predict who's at risk and who has signs of early pancreatic cancer? It's important to emphasize that these are retrospective studies and have not yet been evaluated in the real world, but this is really where we need to be. And as we develop new tools, liquid biopsy tools and the like, we need to implement everything together to give the best outcomes for our patients. Now, in saying that, we've worked very closely with Microsoft, and this is just a simple example recognizing the pancreatic gland. We've trained a computer to find the pancreatic gland, outline its borders, this is normal pancreas, and we compared it to 4 people, 2 radiologists and 2 technologists who are really skilled at segmenting. And you could see there is variation even between the 4 people. So the point is, even the best radiologists and the best image segmenters are going to have some variation. And then we compared it to what the computer can do and looked at the DICE score. Well, in 95% plus cases, the computer is as good as the radiologist in drawing the outline. It's failed in between 3 and 5% of cases. We're working hard on trying to minimize that number, but if 95% of the time it works fine, and in 5% you need to do a little bit editing, that's going to work out very well in clinical practice. We know there's problems when there's low abdominal fat, or there's fatty infiltration of the gland, or there's local inflammation. But we know that regular people, real people, you and me, have some difficulty at times as well. We can kind of guess where the gland borders are. Computers need to find the borders, not guess where they are. So we are at about 95% plus, and there's an article that was recently published about this. So now we have the computer being able to find the gland. And remember, the better the gland is outlined, the better the radiomics is. If you don't have the right gland borders, radiomics is not going to work as well. So the importance of radiomics robustness is dependent on your ability to really draw good margins of the tumor. And you could see in our mind how this radiomics pipeline would work, but the pipeline to really be used clinically in practice is so dependent on the ability to really have the entire process be automated, and radiologists and technologists not involved. You scan the patient, everything happens, and then the images go to the radiologist. That's what we need to be doing. Now, one of the things, a good article about IPMNs of the pancreas, talking about the fact that IPMNs are so common, somewhere between 10 and 20% of patients over 60. And because of that, we need to figure out ways not just of surveillance, because you can't surveillance on every patient. Okay, that would fill up all our scanners, and ACR rules is you need to follow patients for 9 years. That would be undoable, but can we use AI to better define what patients need to be followed and which patients do not need to be followed? That's very important. Now, another thing is, I mentioned before that in radiology we have the images, we have lab work. We're going to have liquid biopsies going forward. There was an article published several years ago, 860 or so patients who were evaluated at leading medical sites throughout the world. They found patients who they felt were highly suspicious for pancreatic cancer or at a minimum high-grade dysplasia based on lab and imaging, and these patients were operated on. These are not, minor surgeries. These are Whipple's procedures and distal pancreatectomy. Morbidity and mortality. Mortality, even in the best of hands, approaches 5%. Morbidity can be very high. These are life-changing operations. Well, it ends up that only 40% of the patients who were operated on actually had a tumor that was either high-grade malignancy or high-grade dysplasia or malignancy, which meant that 60% of patients were operated on lesions they didn't need to be operated on. That's a lot of patients, and that's in the best of hands. So you can imagine how many patients will go to surgery which don't need surgery. Now, there was work done by Bert Vogelstein and his group with ComSyst, where they were able to analyze using computer programs the data, and they found that they were able to triage the patients better with roughly a 60% accuracy. So 40% is terrible, 60% is not great, but it's a lot better than 40%, right? So that's easy. Well, what we did working closely with Microsoft's AI for Good Lab is we looked and said, what if we took the same data? This would be about 3 years later. We didn't reinterpret the CTs. We did not add any lab values. We changed nothing. We looked at the exact data the original papers looked at, where they were 60% accurate, to see if we could do better. And you could read in this article in Pancreatology, the answer is yes. We can be accurate in more than 90% of the cases. We talked about the ability to use explainable boosting machines developed at Microsoft. It's not a black box, it's really a glass box, to be able to understand how the computer decides how to manage a patient after we've trained the patients. And these EBMs have been used with heart disease, breast cancer, in telecommunications, and many other different related fields. But using them is really a generalized addictive model technique, or GAMS, potentially can really help us in terms of managing the patients. We talk about probabilities. We want to know what's the probability this patient has cancer. For example, what's the probability if they go to surgery you're going to find cancer. We don't want to talk about the general population. We want to talk about the individual patient. We want this precision medicine idea going down. And you understand, of course, that if you say a patient has a 5% risk of a cancer, that means a lot different in a 40-year-old and in an 80-year-old. So again, as we work with patients for decision-making, we want to provide the best information with probabilities and likelihood for those individual patients. And the ability to understand a particular patient, the EBM model does that. You can see all the parameters that were looked at in the various patients and the weighting each of the parameters were given. So one of the things we've learned from looking at these cases and studying and looking at data is predicting what features are best at predicting the presence of malignancy. And so you can see on this patient, the pathologic diagnosis was a serous cyst. The correct management would have been discharged. And with EBM, we would have recommended discharge or monitoring, and less than 15% chance that the patient needed surgery. So this patient would have simply been followed. And in that situation, the patient never would have undergone the surgery, which, of course, it was a serous cystadenoma. They did not need surgery. And you could see the explanation of what factors impact lower or higher surgical probability. When you then looked at the entire process of all the patients, you looked at the current, the CTisus, which is state of the art, and you looked at everything with Microsoft, the EBM, you can see that the model was much more accurate. And one of the key things was it predicted that you needed surgery in 222 patients rather than the other model predicting 303, which meant that all of this are true results, but the most important result maybe is that it would have avoided a 92 unnecessary surgeries or a 59% reduction. It really changed the modeling of how we dealt with these patients. Not just this reduction in surgery, but in 25% of the cases, it changed the management. And we would not have missed any tumors. So again, you can see the importance of really building on these techniques. And the conclusion, EBM models had greater sensitivity and specificity for identifying the correct management compared with either clinical management or previous AI models. The model predictions are demonstrated to be interpretable by clinicians. So I think we're looking at this now and testing it on new data sets. And hopefully this can be the state of the art, the standard of care. In this article by Ganga talking about pancreatic cysts, talking about how difficult the frequency of cysts and the management, that in the big picture, the risk of malignancy is very small, but we need to figure out to identify the cysts at risk for progression and not chase those that are going to be benign. Although surgical resection is the only curative treatment option, it carries the risk of major complications despite technical advances. So again, we need to be better, and AI is going to produce this opportunity. This is an approach to the assessment of cancer risks in patients with pancreatic cysts. It's a complex chart. You can look at it, but again, it goes through high risk, intermediate risk, low risk. It's really a challenge because many patients are in the indeterminate category, and it really is not clear-cut how you should manage these patients. We're hoping with AI we can do this. And we'll also have information, VHL mutations, KRAS mutations, and the like. The ability to detect and have more information, the whole ability to look at lab values, things like liquid biopsy coming along, putting all that together with the imaging characteristics can surely and hopefully help us better understand how to manage the individual patient. And again, this whole idea about screening, the whole idea about high-risk patients, but also the fact is not just the high-risk patients. Every patient we scan, you're always at risk. Someone's at risk. So can we do better? Again, applications of AI to standard of care imaging may address current limitations and diagnostic errors that delay identification of pancreatic cancer. So again, we're talking about we need to change the whole pattern of how we do things and our accuracy. This idea about being able to pick up tumors earlier is very real, and the earlier you pick up pancreatic cancer, like earlier you pick up most diseases, will affect how patients will survive. This article mentions some of the early findings. I mentioned them before. Localized CTisus can occur 1.6 years before diagnosis of pancreatic cancer, and that's been seen in 20% almost of pre-diagnostic scans. So again, we do need more studies to really validate these findings, but with our thinking and our imaging and our reading of studies, we talk about this thing about pancreatic duct cutoff. Again, I mentioned that before, but you may pick up that without a tumor. And if you operate at that point, you can save the patient's life. So again, early detection, we talk about duct means there's something there. If I see a dilated duct, I'll say do EUS or MR. The truth is the patient needs EUS and biopsy because there's never a good explanation for why there's a dilated pancreatic duct that you're just going to leave alone. And again, going back to some of the work by Topol, making the point, what about the majority of patients with no risk factors who present at an advanced stage? We need to figure things out. And again, his point is looking at the medical records will indeed be very, very helpful. And again, as I mentioned, we are beginning to find ways to really get into the medical records. Remember, even with Epic, it's so difficult, it's so complicated, and it's so boring to keep reading and reading. We need AI to go through 20 or 30 or 40 years of data and notes and information and be able to ask the question by us, does this patient have any increased risk for pancreatic cancer? Are there any findings that would suggest pancreatic cancer? And then the AI algorithm needs to know what to look for, whether it's diabetes, whether it's family history. We need to work closely with AI to really help us interrogate those data sets. We talk about generative AI, and generative AI is really going to change everything we do across all of medicine. And I think what I ought to do before going into more detail, why don't we stop here and come back and I'll pick it up at this point. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at CTisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.